Good afternoon, everybody. Welcome to the afternoon session. My name is António Carneiro. I'm a medical doctor. I'm a professor of medicine at the University of Lisbon School of Medicine, right here, very close. And I would like to thank, first of all, to the Fundação Gulbenkian, by the kind invitation, the person of Professor Jorge Soares. I'm very happy to be here and very honored to be here. And the reason why I'm here, I think, that I had at the University of Lisbon School of Medicine, we've been producing information for patients on a structured way. I had you may remember, the Harvard Medical. It was a wonderful experience for us. And so I thank you once again very much. I would like also to congratulate Fundação Gulbenkian for this symposium, because really health literacy has become more and more important worldwide. But even among us in Europe, it has become a major issue, notwithstanding the fact that there's a lot of research money for it. So there's a concern about the decision makers about this thing. Now, health literacy can be seen as something for the patient or something for the patient. We have plenty of evidence that shows that people with diseases that have poor health literacy, the outcomes are worse, and also people that are perfectly healthy but cannot interpret and manage the information also get worse outcomes. So on my right-hand side is Lynne Archibald. She is the head of the LASO Association, which is the Breast Cancer Association. I'd like to thank her very much to help me to manage this. I will be shutting up in about a minute. And we'll have all the three speakers that Lynne will present. So once again, thank you very much for your presence. It's a pleasure to be here. Lynne.
Paulo Pinheiro and Ullrich Bauer. I think Paulo is going to start first.
Yes, we will. We will mix.
Okay, it's a double act.
I will explain later.
Okay, so they've been working on child literacy, how they overlap, and I'll leave it to you.
Yes.
So do we?
Okay. After lunch, it's always hard to restart. I know that. We know that all. And hopefully we will manage it with our talks. We decided to put our talks together, more or less, because we work on the same. And that's why we will switch from time to time in our presentation. I hope this gives a bit in this session right after lunch. First of all, I would like to thank the organizers, Carlos Gulbenkian Foundation, for having invited us. I can also speak on behalf of Uli. It was a great pleasure to being invited and to be here and to present our particular view with a focus on children and adolescents. And with a target on health promotion and primary prevention. So we will also cover clinical aspects, but we will have a focus that is placed somewhere else outside healthcare. So I hope this is stimulating for you, and you can follow the talks. In the second part, we will narrow our the description of our work or of intended work in the future into mental health literacy aspects. This will be then the focus that Ullrich will set. So I will start, if you don't mind.
You might start.
Okay. Let's see how this works. Okay, so the first slide, I think it makes sense right after lunch that we provide you with information how we saw literacy when we entered the scene. So we have not been part of the HLSEU Consortium. We are dealing with health literacy. It's about 2 years ago when we started. The reason is easy. We both are working at the Faculty of Education, and we are concerned with health issues, and we were looking for a topic where we thought to combine education and health. And then we came up to health literacy, and then we did what every researcher does when he starts with a new topic, a new issue, screening of literature. And I call this some snapshots that we brought with from our journey through the health literacy literature. And most of what we are going to tell in a few words was told this morning. Some general impressions that we got after the first screening of literature, our impression on theories and concepts, the diversity that is available and the problems that are associated with that, empirical data a bit. Then we also had some information about the history of health literacy. We think it's very also stimulating, and how health literacy has been placed in policies and action plans. So the first impression when we started our journey, it is that health literacy is getting increasing attention. This is just a slide that shows how many articles have been published in PubMed, including having health literacy in the title, and the numbers are increasing. It started about the end of the 90s, and now it's a steady increase that we observed. So the scientific community is getting aware of it, or again aware. So health literacy has been a topic during the 80s, if I remember well, and now it is becoming important, and this is also emphasis by several papers. It is assigned with increasing significance. The solid facts from WHO, I think, is a nice summary. We have heard it. Health literacy has been labeled as a social determinant of health. That makes it even more important, and it has several options, several potentials. As to concepts and theories, it was difficult for us to get an understanding of it, and I have to admit that I still don't understand right well what health literacy means. I know what it can in the context where we are living, we are working with children and adolescents. It's difficult. We are struggling with that, and we are trying to find out what it can mean for us. So it is basically defined. But there is little sharing of a common understanding. This is the first diagnosis we met, and it is content and context specific. And I think that was a breakthrough, the systematic reviews that was made by the HLS Consortium that impressively demonstrated. We have 17 definitions available, and even when we go into the countries and into single languages, we have a different notation of what health literacy means. So it is embedded in cultural contexts, and even within countries you may find 2 or 3 translations for the term health literacy. I think the Dutch have 3 of, I assume, no? Yeah, that's it. And in the recent past there was a call for the development of integrated trend, and it was extended. That was interesting for us to know about that from a more clinical risk understanding to a personal asset approach, as it was described by Nutbeam in a paper of him. And these are some of those extended definitions. And this was for us the signal that we have also now opened opportunities to go in with health literacy when we think in terms of health promotion and prevention. A colleague of us, he tried to reallocate the literature that he had found, and he went through the literature, and he could identify, and it was also mentioned in several other papers too, that health literacy came up for the first time as a composite term 1974, and it was in the context of school health education curricula where teachers were addressed. This was not followed up. We could not find any information on that, but what we observed is that then the dynamics was that health literacy was picked up by, especially in clinical context, and now at the end of 90s, beginning of 2000, public health is becoming aware of its potentials, and now it is what we like to see a bit is that we come back to the educational sector, and then that we have all the perspectives putting together. So we have a diverse situation as to concepts and theories, but what was for us then surprising a bit is that when we look at the empirical data, what is reported, that we have fairly consistent data suggesting some kind of evidence. This was also discussed this morning. We have high prevalences of low health literacy, even in high-income countries. We can describe inequalities, or let's say it follows a social gradient, if I want to be more precise in the description, and many papers consistently report associations between low health literacy and poor health outcomes, and that covers all the outcomes you can consider. Even if you look at mortality and mobility rates, you find associations. The last snapshot from our journey was a look into the policy papers, and we found that it is included, or has been included, is increasingly included in European and also in national policy papers. The latest we found was in Health Literacy Action Plan that was recently published from the Scottish NHS. So we had a good impression about HL and still have. It's an interesting topic. But then in the next step we asked about what about children and adolescents, where have they been included in recent or in the past research. When we looked then, went back to the policy papers, we find some information. It is written something about school-based health literacy programs and promotion of health literacy programs has to target different age groups. But when we look back to into the scientific literature, we only found poor information then at the end, not enough or sufficient information to answer questions that are related to the childhood and adolescence ages. We have limitations. This is our interpretation of the theoretical and of the theories and concepts. We have limitations in this data to be used, or to have to use them also for the younger age groups. And we found limitations in empirical data, almost none directly targeting the young age groups. We have a body of literature giving information on low parental child health. So our conclusion then was that this lack of data, misfits with the importance that is given to childhood and adolescence, especially when you think in terms of health promotion, sustainability of programs, and so on. And that was the stimulus to. Now, you want to continue with the presentation of our consortium, where we started then to.
Can you hear me? Yeah. Okay, great. It's an opportunity to say hello again from my side too. Paulo, if you don't mind, I will take the other side.
Do it.
Okay. So approaching the gaps, our consortium's work started within the proposal we made 1.5 years ago, and it's in multidisciplinary psychology, sociology, social work, and some others actually. I think this is one of the specifica we got in the discourse now, that we are coming from medicine to other disciplines, and some of us from social sciences are in the discourse for many years, but now new colleagues are coming in. Now it is funded by the German Ministry of Education and Research. It's a consortium, and now HLCA is for us very common, and we are starting to make this consortium more popular. Everything okay? Are you capable to see the slides? Okay, great. We got funds for 10 projects under the HLCA umbrella, and we started just now. And starting means that our work is concerned with the HL, health literacy concepts, development tool of concepts. We are looking to develop tools to assess health literacy in childhood and adolescence. This is another important tool. Actually, we got it in the forenoon, that we are most focusing on adulthood. And now we are going a step further on. We are going into the intervention level and try to develop and test programs to promote health literacy in childhood and adolescence. So it's very close connected to health promotion and primary prevention. We are talking about children and adolescents, and we are looking for social environments with impact on child health and development. So in a way, we are changing the focus from pure behavior factors to more or less social determinants or determinants of the context. So, starting from that point, our journey began in health in childhood and adolescence, the main issue, then coming through health promotion, primary prevention, and then finishing now at health literacy in childhood and adolescence. And as you all can see here, we got 2 levels of discussion, or 2 areas, the user area and the provider area. We are talking about the children and adolescents as users, and we are talking about the providers, adults in the families or wherever, and the social systems and settings, surroundings. Let's say, in terms of social sciences after the spatial term, we're talking about the families again, the schools, healthcare and social care systems. And there is a double perspective, two perspectives. The demands-on perspective regarding user and provider, what minimum health literacy levels are to be defined, and the needs for perspectives, also related to user and provider, what are the needs for health literacy? We don't know much about the needs these age groups can present. Okay, we can't provide research because we just begun. This is our research context, our structure of the although it's a project funded by the German ministry, but we got the look to invite colleagues from Wales, Portugal, of course, Austria, and okay, you all saw that most of them are very well known in our research context. Our basic research we are dealing with is our first block or our first pillar in our 3 years period. This is 3 projects. The Ticamo project, Paulo is talking about later theories, concepts and models, development of a comprehensive theoretical and conceptual framework on health literacy in childhood and adolescence. Our Mom Child and our MOLA project, both are projects where we try to develop tools to measure health literacy in childhood or in adolescence. Our other pillar is the work block 2, that is mental health literacy, another term connected to health literacy, but it was coined in the 90s in another context first. We got an analysis of needs for primary prevention of families with mentally ill parents. I'm talking about that later. We got a provider MHL project where we are involved in a multi-level survey on professionals and provider skills to interact with mentally ill parents and the unaffected children, and the teacher MHL project I'm most interested in, actually, because it tries to tries to focus on schools and teachers and with professionals, actually, who are very, 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 very strongly engaged with children and their health and their development, and therefore we try to make an assessment and later on promotion of teacher-specific mental health literacy and their skills to promote the children. Okay, another work block of our project is e-health literacy. Jürgen Pelikan mentioned today. It's mostly done by our research partner in the south of Germany, in Freiburg. It's called Media Protect, where we make a cluster randomized trial on the effectiveness of a brief parental intervention to prevent problematic screen media use in children from 4 to 8. Our Pretty project is a systematic review of digital health efforts for children and adolescents. The first one, or still the first one that has to be done. And the ELMI project, this is quite interesting as well, because it's an ethnographic study on health-related use of new media among disadvantaged adolescents. And this is most interesting because I think it's one of the first approaches where we try to look on health literacy in processes. While health literacy is a concept, since it is a concept we can call doing health literacy as well. It's not just a skill or competence, it's something what is embedded in social context and it's embedded in other actions. And so we decided to choose an ethnographic access to this field to be involved in the way people, adolescents try to choose the health literacy way or not, health literate way or not. Okay. Okay, coming to the end of the part of our consortium, just to show a few snapshots of that. Another project is our synthesis. This is something very specific I like to provide, because it got the objective to make clear after 3 years what we made and to put together, and more useful to put it into practice. So the Ministry of Education and Research gave us the opportunity to put all the results together, prepare for a second 3-year working period, and to prepare a period where we try to go into practice. So basic research turns into practical action or interventions. That's what we try to prepare here in this field. Okay, Paulo, I think we are still in time.
Yeah, we are.
Hopefully you woke up after lunch. This was just an introduction to what we tried to make a little bit clear in the next step, when we change to some selected issues of the work.
Yes, and I will now continue with some preliminary insights into our theoretical work. I mean, we have been active. We have not been waiting until the positive response came, and this is one of the 9 projects. Well, to start also the discussions, to put some thought-provoking information to provide, because we don't know what it means, and we were thinking about how to approach theories, concepts, and models, how to develop them especially for children and adolescents. We know the children and adolescents are not one group. So what did we do? Of course, this is labeled now as preliminary work. This is what I'm going to start, and I decided to describe some entry points that are attractive. We don't have to follow up them, probably. We will have to, but we have to think about if they are useful when we want to target the children and adolescents, especially when we think about in terms of health promotion and primary prevention. And at the end, just one slide to our project. It's in a kind of a vignette. So this is what is going to expect you within the next minutes. I hope we are still all on track. Our first entry point is obvious. When we read the literature related to health literacy, and we find out that there is only poor information available about children and adolescents, we start to think about, if this is usually targeting the adult population, what can we use out of it, and how can we adapt it to childhood and adolescent. We have some information available, or some attractive entry points, let's say it that way. There was a series of articles published in Pediatrics in 2009, and they proposed to use then some frameworks, especially more from psychology or from education. Piaget's framework on the cognitive development, and probably mixed up then with Vygotsky's model on the zone of proximal learning and the scaffolding, and to put it together with Paulo Freire's critical pedagogy, and then direction to children and adolescents. I think we can also make use of Nutbeam's work in the past, the famous conceptual model. Let's say it's typology on health literacy, dividing it into, splitting up into functional, communicative, and critical health literacy. I think this is a good entry point to think about it. How does this work in children? Does it work, and how could it work? What does it mean? We have to modify. And the same is true then for his his extension, or is describing health literacy as a clinical risk and health literacy as a personal asset. We can continue following these pathways to a direction to childhood and adolescence. I don't know where we will end, because we started to collect the entry points. And of course, HLSAU work is an attractive to think in terms of children and adolescents. The model that was developed includes life course perspective. The question or the challenge would be then to continue developing it, to refine it, and to validate if it is applicable or not. The same is true for the HLSEU metrics. I think we have a nice framework that we can apply, and we will have to test it if it is possible, and how it is possible to do it with children and adolescents. A second entry point, I found it convincing because it is well to memorize. Take care of 4Ds. This I found from a presentation given by Rothman in 2011, and he postulates that if you want to outline a meaning of health literacy for children and adolescents, there are 4Ds that you should at least always have in mind. That is the development. Children obviously differ in their developmental ability. From birth until they are adults, and that continues even after that. They are dependency on parents and other adults for care and healthcare. The disease epidemiology is completely different than that from adults. So they have other risks they are exposed to. They have other disease patterns, other disability patterns, and that what then is labeled as demographics relates then to the social or socioeconomic issues that clearly also affect children's development and healthcare. We then opted in the last time on a third entry point. We thought, okay, let's rethink the basic concepts that are within health literacy, and that is health, of course, and that is literacy. And health has been dealt mainly in public health or in health sciences, and literacy more in the educational arena. And when we screened the literature, we are all familiar that we have a different understandings, different meanings of health, different models that are available, and each one has also different implications if you want to go further. The same was also true for the literacy concepts or for the literacy perspectives, and this covers cognitive perspectives or psycholinguistic perspectives and sociocultural perspectives. This relates to the new literacy perspectives, where the doings are important, rather than the abilities. And I think this adds to our understanding of building up a framework for children and adolescents, and well, we have more options that we can probably make use of. The other point is, if we make the analysis of these two concepts, how do they interrelate? So we can try to do again the synthesis, and then we had to adapt it to developmental stages or to the development, let's say it that way. Starting by infants, probably. I don't know. We don't know when is health and literacy starting, and how does it start? How does it develop? And the development perspective then got a new notion recently, and this is our fourth entry point that I want to outline here or to put a highlight on. There was a series of articles recently published that highlighted the contribution of the sociology of childhood to research on child development on the one hand, and on health, child health too. And the rationale from these authors, from Brady et al., who published this, is that we have, let's say, a shift of paradigm. And if not a shift of paradigm, at least it's a shift of the focus from seeing children as immature becomings, it's, let's say, the last 20, 30 years, on their way to adulthood, to seeing them, and this is how we see children currently, and how we want to see them as beings and as competent actors with a social agency of their own. So they are not only influenced by, but also influencing their social worlds. And if we understand then children as a social group, draws then attention at their rights and the structures in their living in, and that enable and restrict control over their lives. The authors mentioned three issues that at least are worth being followed up and being discussed. And the one point is we consider children, or to consider children as a social group would also mean to consider them as a minority group. And that implies that we have to build up an understanding how they are currently placed and perceived within the structures of societies and how they relate to other groups. understanding the dynamics and the intergenerational relations between the children, the parents, and the adults. And then we come back to power relations between children and the world around them, their social world. This is one point that we certainly need to discuss, and where we think that we can benefit from. Also, when we think then, or continue thinking in terms of what is health literacy then, and what is child health and child development. The second issue that was raised is when we consider children as social agents, and if we want to have them as a co-constructors of the social worlds, if that's our contemporary understanding of childhood, then we should build up the understanding of child agency to understand how they deal with health and well-being in their everyday life. And some other questions that arise. I just have a look if I put the focus on something. The question whose actions should impact on whom. So there's, again, power relationships between children and their social environment. And the last point that refers then, or last issue, seeing children as beings and not just as becomings, means that there is no typical child, and that we have differences in every variable we can then measure or we can target, and that each child is then subject to different structures and discourses. And the last point probably should be something that we should keep in mind when we continue doing our work, when we do conceptualizations of the child and then of the child health that homogenize and decontextualize children, then we are probably on the wrong pathway, and we should find for alternative pathways. So these are some entry points. They will certainly merge into our TICOMO project, Theories, Concepts and Models on Health Literacy in Childhood and Adolescence. The vignette, the overall objective is to at least to develop a comprehensive theoretical and conceptual framework for these age groups. We will have time. This theory project will take 3 years, and we are in the fortunate situation to get it funded for a young researcher who will join us, or has joined us. Issues to be addressed, I mean, this is what has been said before. Another issue what I want to point out is that we also provide frameworks that are workable and applicable, so that we can use it, what we divide or conceptualize, what we theorize and conceptualize, that we can make use of it for development of measurement instruments or as a theoretical foundation for interventions. This is one of the, let's say, major aims of this project. We will use a variety of methods, those who are usually applied when we do development of theories and concepts. And we will have, I mentioned it before, a duration of 3 years we can work on it, and these are the contacts from our 2 co-workers who were mainly involved in this project. So that's the TICOMO. Oh no, I will continue. 2 issues probably that are also important. I mean it's very complex, you see, and the more we think about it, the more complexity we can bring in. We brought very much insight because we have resources to tackle them, and we should consider them at least. General issues, I call it general issues because this affects health literacy also in general, also the adult, if we think in terms of adults. How do health literacy, health determinants, and health inequalities interrelate? It's certainly something that will affect also when we think of child health literacy, when we think about it. And Stefan, he gave a presentation, so I don't have to go deeper into that. And the other thing that is for us important, ratings, classifications, or categories. What is adequate and inadequate when we think about children and adolescents, even when we think about adults? You know, how do we make the ratings? Health and health inequalities from literature is that, of course, correlations are well known. It has been reported a lot this morning, but a recent publication also highlights that we know only little about the causal relationships. We don't have any systematic reviews available. We don't have any studies that explicitly have addressed this. And so it is an open question to go for. And it is a task of the research scientific community to find the answers. And there are, from our point of view, several options. And it was mentioned in Stefan's talk this morning. If you question, is health literacy a determinant of health? It might be. We don't know. We have other options. We can also think about socioeconomic status acting as a confounding variable, which has an impact on health literacy. The lower the socioeconomic status, the lower health literacy, and we know it from social epidemiology. Socioeconomic status is strongly correlated with the health status. The lower socioeconomic status, the lower the health of populations. So this is a second option, or a third after the mediator variant that you put in, or the moderator variant. So we have to go back to epidemiology, to social epidemiology, and find the answers to these questions. They leave it open. Another point that we are especially interested in is we are talking about health literacy as a determinant of health. But we are asking, especially when we talk about children and adolescents, what about the determinants of health literacy? How does health literacy develop? What is some kind of etiology? What can we report about that? And these are open questions. And we opened this by finding out some labeling. We would say the one point is having health literacy as explanations for health outcomes. And now we also have to put a focus. At least this is what we call for, to health literacy as explanandum, as something that has to be explained. And this will help then if you want to think about development of programs of interventions for promoting health literacy. You have to have, to a certain extent, knowledge about the determinants of health literacy. Okay, and the other point, just probably brief. I know about time. Are we in time still? Okay, adequate or inadequate health literacy. When do? We just brought some, we call it case study, and it's really thought-provoking case studies to discuss about. Diet and health, we could think about. When we have a look at we have enough written literacy instruction. There is a plenty of cooking books available. You can order them. They are target specific. You have for children. You have for certain lifestyles adapted. Availability is there. We also have enough oral literacy instruction, at least in Germany. I can report about Germany. So people who cannot read, they have the chance to watch in TV one of the overwhelming programs that they offer about cooking and so on. That should also not be the problem, and we can assume that it has some kind of target specificity, at least in Germany. We have an increasing offer of interactive literacy instructions. You can use apps. You know how long your egg has to be boiled, and so on. And we have access and availability. We need to produce the meals for healthy, healthy eating behaviors. And if we contrast this with epidemiological data, it is disappointing. I think we have the obesity epidemics, the reportings and the warnings, especially in children. We have other data reporting that 30%, at least of German adolescents, don't leave home without any breakfast. And this, for us, is the question. In this case study about diet, we have an overwhelming provision of instructions. We have the access and the availability of the goods. But what we know is, in general, data, the evidence, the quality of data is not that high when we compare it to other conditions, disease conditions or risk factors. And the question is for me, when am I allowed to say I have poor health literacy or I have a good health literacy? Because I personally, I can make use of all of these offers, but I like junk food. I go to McDonald's from time to time. What about my health literacy? So this could be a provoking question, but we have to think in that terms, especially when we talk about children. Still time? Or shall I skip the second case study? Yes, I would say. Yeah? Okay, another case study is a different content. Global warming and health.
The okay means skip.
Okay, so I skipped this. I had prepared just to raise other questions. By global warming, we know we have the evidence of the data. This makes probably different from diet. We know about the hazards and we know about strategies, but the results are poor. And the question is, when am I health literate or not in this sense? Summary, we have gaps, of course, and you told it, so this is that it is a godsend for research, so we are happy that we have...
To have gaps is always a godsend for research, but another point maybe as well, we are talking about health promotion again. Health literacy brought us back to health. It's a gift, it's a godsend, or whatever. Maybe it is, yes. Somebody said worst case? No.
It's our work.
It's our work. I heard worst case. Interesting enough, huh? Okay, this is something what is connected to our consortium's work, new projects we are intending to realize. I want to give an introduction into another issue we are dealing in our consortium's work. It's our second work block, mental health literacy. I think we got a quarter of an hour left. Is it okay for you? Okay? Okay. I try my best. So promoting the provider's mental health literacy to promote mental health of children at risk. We are in the work block together working 3 universities and 3 sub-projects. That means here the sub-project NAP, Provider MHL and Teacher MHL. I try to offer some details about all 3 projects. At first, if we talk about children of mentally ill parents, this is our starting point. So we are talking about children living together with at least one parent who suffers from mental illness. And then we are going to talk about mental health literacy in terms of how to cope with it, how to cope with the burdens, with psychosocial risk factors in a family where at least one parent is affected. Actually, we didn't do that. We couldn't do that, but we didn't do that. We went back to another perspective, the family perspective. If we talk about children and adolescents, it's crucial to talk about the surroundings, environments, parents, families. And so we took a family perspective on that. Families with at least one mentally ill parent and not yet affected children, that makes a difference. If we talk about not yet affected or affected children, of course, then we're going to the mental health and psychiatric care services. We look on the municipal social services, child and youth services, and the schools, teachers, and educators. We were there before. We tried to make clear that if we talk about children's and adolescents' health literacy, we have to take into account the environments. And these are 3 main parts of the environment of children's at risk. Okay, coming a little bit closer, if we're talking about the risk factors of these children living together with mentally ill parents, in Germany, and very similar in the international discussion, we can state that one of the populations at highest risk for developing mental disorders are the children of mentally ill parents. The risk to get ill is 4-fold higher than for the not affected population. And in Germany, you can say about 3 million children and adolescents experience at least one parent with a mental disorder every year. And to make clear what that means is about 1/4 of students in German schools and about 1/4 of students in Portuguese schools, of course, as well. So it's a lot. Actually, it's a lot, children at risk, and this is a reason to develop tools of health literacy promotion to help these families. That was our starting point. In the general discussion to the issue, we got the diathesis stress model to explain how mental illness occurs, and what is most important is that we won't talk about the genetic predispositions, because it doesn't make a sense for us, because we can't deal with it, we can't intervene. And so we are talking about the psychosocial risk factors that interact with the genetic predisposition and have their own impact on mental diseases. And this is our field of action for health promotion and primary prevention, of course. So social environments not only contain risks, they are not only risk factors. We talk about children at risk. We can say all in all, only 1/3 got a permanent disorder when living together with a mentally ill parent, and another 1/3 got disorder from time to time, transient, and 1/3 is not affected by this in the life course, not affected by such a strong risk factor like the mental disorder of one parent. So if the children can cope, differs, and it depends from the individual, familial and community resources to accomplish developmental tasks, of course. So coming to mental health literacy now, the term was coined in the mid-90s by Anthony Jany, and it was the objective to draw attention on the public as target for better identification and management of mental disorders. And following the definition, it means knowledge and beliefs about mental disorders which aid their recognition, management, or prevention. So we got this, the term coined, the emphasis on knowledge that is linked to possibility of action to benefit one's own mental health. And there are several components: knowledge, recognition, help-seeking options, self-help strategies, and first aid skills. But what is happening with that in the affected families, in the families we are dealing with? Coming to that, we actually can state that there's a lack of recognition by the person that she has a mental disorder. For example, people seeking treatment for anxiety or mood disorders, and very well known is that we got some time from the onset of a disorder to the recognition or to seeking professional treatment. And this is in the main 7 years or 8 years, recognition 7 years, seeking professional treatment 8 years. And this is a long duration, of course, where a lot may happen in the families, and the risk factors are not observed, nobody can help, and mostly the children are alone with their parents with these problems. Very, very similar is what we call the overlapping waves of action. So this is similar because we just try to show the trajectories regarding the increasing existing self-help, the first wave, then adopted new self-help strategies, and then the third wave, if they do, seeking professional help. This is very similar. It takes time when nothing can help in the families they are with their own. So the parental mental disorder, use of self-help strategies, lack of recognition turn into burden for children, of course. The family perspective contains that there is a lot of disorientation, especially the children don't know what's going on in the families. Feelings of guilt, children do believe they are guilty because their parents are ill. It's a taboo, it's stigmatization, isolation, care deficits, taking care of household chores. So especially for the children we can say they got a lot of burdens and they don't complain. And if they don't complain, we talk about that, what is called parentification. So children at risk assume the tasks of providing care for parents and put our needs aside. So they become an adult, actually. You may see it here. It is the children's face is serious, like an adult's face, and the adult's face is childish. So it changed. It's a sort of role change that happened in the families, and that's what we call parentification. There's a lot of emotional pressure on the kids and all that stuff. This is one of the main psychosocial risk factors we can assume. We got some others. If you look at the children, especially in the terms of successful schooling, lack of sleep, poor concentration, learning lags, absence from school, feeling ashamed for that what's happening in the families. And from that we can distinguish between two phenomena, a withdrawal and drop in achievement, what we call more or less internalization, or engaging in aggression angry outburst, law breaking, and so on, what is more or less coined by externalization. Okay, school handicap, we mentioned already. I try to hurry up a little bit. There is increased probability of having problematic educational biography, and that turns again into new and long-term problems. So there's a family problem, children adopt to, they got problems in their own biography, and then other problems occur, like school problems. And this is a circle they get in that makes one problem after another. Okay, looking to the care systems that try to help these families, they are mostly poorly prepared to detect and meet the needs of the families. Children are not considered to require support, even if parents, adults, are coming to a doctor. They don't ask for the children for several reasons. The issues of children are neglected, and mostly due to parental concerns of child abduction, of course. And both parents and doctors, or in psychiatric care systems, know that child abduction may be a risk. Actually, it is not, but the fear of child abduction is very, very, very strong. Okay, so we got that what we can call a treatment gap. It's a poor use of sometimes well-developed health promoting and primary preventive services. Looking at the schools is very similar. We got a potential protective function, but also risk potentials. In schools, there's an informal awareness at best, but teachers are not prepared to respond to the situation. They're rarely able to decode phenomena, and they are rarely capable of disposing of means, to dispose of means necessary to provide adequate support, of course. Okay, coming to the first conclusion here is there's an insufficient practice of support for children, and we got a particular challenge for professional development. Our approach here is threefold. It's our NEP project, it's a provider MHL project, and then our teacher MHL project. Coming back to that, our starting point in the research on the children of mentally ill parents. That means we got our NEP project. This is our needs for primary prevention in family with mentally ill parents. This is to identify the needs in the families, and it's based on a qualitative survey. We got the provider area where we try to find out something about the knowledge and the needs of the professionals in healthcare systems, in child and youth services. We got qualitative-based method and try to build up a topology about the needs and the knowledge, and then turn into a quantitative survey. On the search level, it's the same. We are going into the schools, ask about their knowledge. We're going on with a qualitative based method to establish a topology of needs, and then going into a quantitative based survey. Okay, very fast, because you should have the opportunity to ask for that. After all, we end again where we can make some prospects. First of all, of course, prevention in this field works. In view of the fact that only 10 to 30% of such high-risk families accept offers to therapy and assistance, this will be the first primary preventive and health-promoting approach to protect the health of an as yet unaffected but particularly burdened high-risk group. Okay, coming back to the prospect number 2, means just what I tried to coin before. We are coming closer to an understanding of health promotion that enables us to talk about context, environments, and much more than just knowledge about our health or the healthcare system. Maybe this is useful, maybe not actually. We got some time left, but I would propose to spend it for our discussion. Thank you very much.
Just a little housekeeping. So Dr. Jany Rademakers is going to speak now, and then after her talk, we'll have discussion about all three and questions. And then I hear that you missed your coffee break this morning, so there's going to be a coffee break this afternoon about 4:15. So we'll aim to have a break at 4:15 before the last session. Dr. Jany Rademakers is a clinical and developmental psychologist working in the Netherlands. She's worked in health literacy most of her life. And she's been particularly involved with questionnaires, designing, translating questionnaires. And today she's going to talk about a little bit about the rest of Europe, particularly Eastern Europe, and health literacy there. Thank you.
Thank you very much for the introduction. It's very nice that you say that I spent most of my entire life in this area. But I think that health literacy, the topic is a little bit younger than I am. So that's, but that gives a good impression. I want to thank the Gulbenkian Foundation for inviting me to be at this interesting meeting. I've learned a lot today. I'm happy to show a European study that we have done for the European Commission. And the study is called HLCA for you, but it's Health Literacy for Europe. It's a review of health literacy and a mapping of the health literacy policies in all EU member states. What we have done, and as I told you, I share with you, not out yet, it's really very fresh all. We done this study not together. I work at the Netherlands Institute for Health Services Research, but we did this program together with other partners. We couldn't do it without them, to be quite honest. One is the National Institute for Public Health and the Environment in the Netherlands. The other one is the European Organization for the Public Health Alliance, which is more a patient organization who does a lot of advocacy work also in the area of health literacy. And we work together with our subcontracted experts, country coordinators in 26 member states of Europe. And they have provided us with main information about what is happening with health literacy in their countries. Because the European Commission gave out this research money because they said a lot is happening in the past years. We already saw in the previous presentation the immense rise in publications, for example, scientific publications, but a lot of is happening in institutions, hospitals, in countries on a national level as well, and nobody really had a kind of overall picture. So we got a very nice task to provide that overall picture and to say one thing at least, that is not a simple thing to do. It's more like an impressionistic painting, you should say, than that all facts are really, every project is in it, but you should consider it an impressionistic painting. But I start with telling you what we did in the project. We had 3 work packages. The first one was relatively easy. It was an assessment of health literacy intervention studies in the European Union. There have been a lot of studies in especially the United States on health literacy interventions, their efficacy, their cost effectiveness. And the idea was that we would do the same, but only on intervention studies that were performed in European member states. So that was the first work package. The second work package was the mapping exercise, where we would look at existing policies or plans for policies in EU member states aimed at improving health literacy. That was one very important health literacy, and we made it very easy for ourselves. We didn't define what health literacy was. The people who did projects define health literacy, but it's not when they don't call it health literacy, it's not included in our picture. For example, education in general, for the general public, or patient empowerment in general, those are not included. Somewhere in the project, health literacy should be mentioned. The third work package was more of a statistical modeling exercise, where the European Commission asked us to, on the basis of publicly available data, census data, which you can have from your statistics office in every country, and on the basis of, that's a very, with which countries can estimate the level of health literacy in their country. That is, for example, for countries who do not have the money to do a real good I've done a study with the HLCA questionnaire, and the other 8 countries have done that, but not all countries have that resources to do such kind of studies, but they have the data already. So if they use our model, with respect to health literacy. I'm not going to talk about that today. I'm only going to the main results from the first work package. This was a standard, let's say, systematic review where we looked at intervention studies, and there were 4 inclusion criteria. The study had to be done, let's say, the intervention and the study had to be done in one of the 28 European member states. It had to be an intervention study, so all those many publications on research or, let's say, on the epidemiology of health literacy or about concepts about health literacy, we didn't look at that. We only looked at intervention studies. The third thing was that the study had to be about health literacy, and first the European Commission asked us to only use studies which have put a more objective measure of health literacy in their design. Well, that was a very funny thing to ask, because we only found, I think, 6 studies which did that. So we said, no, we cannot do that. We should also include the other interventions that use more subjective measures, the self-perceived health literacy. That was one of the discussions which came on this morning a little bit. But, so then we could have higher numbers of studies included, but still we only found 20 intervention studies in Europe. So that's not much work to do, I think, because, as we will see later, it's not that there are no interventions going on, but the interventions might not be evidence-based. They are out of goodwill and enthusiasm, good thing, because motivation of for example, care providers is a very important thing based on evidence, and they are often not evaluated. So we need much more intervention studies. As we looked at the quality of the studies, for yourself, 13, the quality was weak, the design was weak. The 5 were moderate and 2 were more strongly designed studies. So that is important when you want to say something about what can we learn from these intervention studies. It should be nice if the studies would be a little bit more better designed, well designed. We couldn't find any study about cost effectiveness, so we cannot tell at this moment whether such an intervention helps in reducing costs for the healthcare system or reducing costs whatever, because there is no cost effectiveness study. So that's an important thing as well. Most studies were performed in the United Kingdom and Germany. They were really at the top. Austria had 2. Especially there were no studies from eastern or southern part of the European Union. As you can see later, the whole concept of health literacy has not caught on yet in some countries, at least in Eastern Europe. The types of interventions which we found in those 20 studies could be categorized in 3 types. One was plain and simple, I would say, interventions aimed at improving the health literacy level of a certain group. Patients, diabetes patients, healthcare providers, but improving the health literacy level. The second one, you had a different design that were studies in which the intervention was tailored to different health literacy levels. For example, you want to have an improvement in the self-management of diabetes patients, and you make an intervention for groups who have low literacy and groups who have higher literacy levels. So that's a different approach. You are focusing on a different outcome. And the last one were interventions in which health literacy really was not part of the intervention, but the authors described the effects of their intervention apart of separately for people with different health literacy or numeracy levels. So they used it as a kind of determinant, just as age or education. We were asked to say which interventions would be promising, which is a very difficult thing to say when you have only 20 studies, of which 13 were weak. So promising studies, you can say it's just our first impression. But the promising interventions were the ones that tailored their efforts to the needs of either a patient group in general or specifically low literate groups. So that's a very important point. Furthermore, there has been already today much discussion about the concept of health literacy, and you can take the narrow focus on it's the more functional health literacy, which focuses on knowledge and understanding information, more cognitive aspects of information processing. But in the description of health literacy and critical health literacy, well, we found really looked at those separate, and that especially the ones that address critical and interactive skills and competencies, so not only knowledge, but also helping people to do things in a different way and giving them tools to do that. Those were more interventions that focus only. The reason for that, and another, is that where you learn people to do something otherwise, you empower them, and they feel more competent to behave like that in a similar situation later. So you have a positive impact, always a good thing, but also on motivation, self-confidence, and having stronger feelings of control. So that's the thing which we could say on the promising interventions. Our conclusions for the first work package was the number of intervention studies in Europe is scarce but rapidly growing. The majority, I think, over half of the studies were from the past 3 or 4 years. So we have said that I think in 5 years there will be a huge explosion of intervention studies. I hope there will be a huge explosion, since the quality of the studies was not so good. But what we have found was in line with the same findings from other reviews. For example, Berkman, who you already showed, in the United States, they have done a similar kind of systematic literature review, and we came on virtually the same findings. And the most important thing is that with such kind of interventions, you can have a positive effect on personal competencies of people. Now we go to the impressionistic painting, and that's the mapping exercise. Our target was to map and analyze policies in all EU member states, and as it was said, on a national, a regional, and a local level that are planned or that already are in place in order to improve health literacy. So health literacy, I was very happy that that was a real focus and not everything which is very related. what we have agreed with the European Commission is that we predominantly looked at national and regional levels and not all local grassroots initiatives, because we were very unsure that we would be able to cover. We used three methods of collecting desk research, exploring websites. One was literature search, also grey literature. You know, grey literature is not the scientific literature. The most important source of information were our country coordinators in 26 countries. And we have also, after that, asked the people from the European Public Health Association to check and double-check the information. So, what came out of that? Our mapping exercise resulted in 82 different policies, programs, and actions in 16 countries. So, you know, there are 28 member states, so 16 have some kind of program or policy on health literacy, which means that 12 do not. It doesn't mean that there is nothing happening, but they don't call it health literacy. They might do other things, but they don't. There are 6 countries that have a national policy, and national, you should take that a little bit broader. For example, Austria has a national policy. It's part in national documents, the Gesundheitsziele. Yeah? Ireland has one. Italy, Portugal, Spain. All 3 were in the have. In their national health programs statements about health literacy and that action should be taken upon health literacy. And the United Kingdom, to be more specific, Scotland and Wales. England has not got a specific program, but you showed the last, how do you say that, the policy from Scotland. But those 6 countries have a national policy. In the other countries, the other 10 countries that have activity in the area of health literacy, it's more from different stakeholders take initiatives. It's uncoordinated. It's not that people don't talk with each other, but there is a lot happening, but not top-down. It's a lot bottom-up and, well, everywhere. This is to give you an impression about what is actually in those programs or in those policies. Well, the policy most countries start with is some kind of policy development and agenda setting for research, especially the same what we talked about with the HLCA study, or what was done here is about how many people in our country have low health literacy? That's one of the first questions that come to mind. So a lot of the policies are aimed at getting a good overall picture of the situation in your country. And from that on, also setting the agenda for further research. To gain knowledge about the levels of health literacy, there has been a lot of discussion, and I think you are aware of that, about which instruments to use, because when you have many definitions and conceptualizations of health literacy, there are also many instruments, and those are very, well, discussed, but also many instruments have been developed in the past, let's say, 6-7 years. There are in several countries, and Christine has shown that this morning, a kind of alliances or working groups. There is one in the Netherlands, there is one in Germany very recently, there is the Nordic working group, and that's an attempt of the stakeholders to try to form some kind of coordination when it's not from the national government or any government, then that the stakeholders try to do it themselves, more or less. Well, there are a lot of programs and actions on the improvement of health education, self-management, and they take into account health literacy, improvement of health literacy, just plain as it is, or the health literacy of professionals. A very common activity is the improvement of health information, both orally and written, so making leaflets easier, making websites easier to read, those kind of very basic activities for to make information more easily accessible for people with lower literacy. Improving digital information, that's one of the things I just mentioned. Identifying best practices, which is not very easy since, well, it's all starting up and not very well evaluated. And more in general, supporting vulnerable groups, empowerment, prevention. Those are, when you ask people what are the targets of your policy or your program, these are the kind of things people come up with. I try to categorize them in what kind of activities have we found, and then it's over 100% because sometimes people put their program in different categories, but most of the time we are dealing with intervention programs. So that's what I said before. We have found very few intervention studies, but most of the programs that we found are intervention programs. So a lot is happening, but it's not yet well evaluated. I think it's a matter of time that we will get the research that has to come with those interventions. Well, the second one is guidelines, how to deal with people with, which is more common nowadays in several member states. And, well, policy, as you can see, is the third. Christine showed this policy cycle this morning as well, and we have tried to see of these 82 policies, programs, and actions where they are in the policy cycle. And you can see that the majority is in the implementation phase. The majority is actually working. Something is happening. People are not planning it. People are also still talking about defining the problem and setting the agenda, but a lot of the work is already being implemented. What is very clear also from this slide is that only 1 in 4 of the policies and programs has a kind of evaluation in it. It's when we asked it, we didn't ask, have you got results from the evaluation? We've asked, is there an evaluation part of your program? And only in 1 of the 4 interventions, people said yes. So that's something we should hope will ameliorate. Currently, the most active countries in the area of health literacy are Germany, Ireland, Italy, Portugal, Spain, and the United Kingdom. So I'm very happy to present this to you all. And you might think that you're starting in a way, and in Europe, you're really doing not so bad. You have a national policy, you have research, you are active, so be proud, I would say. Recently, especially I think after the finishing of the HLCA study or starting with the HLCA study, Austria, the Czech Republic and the Netherlands are becoming more active. But as I said earlier, the concept has not caught on in Bulgaria, Cyprus, Estonia, also not in France, which is a little bit different because a lot of activities are happening, but they don't use the term health literacy. There is a French term, but it's not. It's just not common. So therefore, France is also here. Greece, Hungary, Lithuania, Poland, Romania, and Slovakia. When I looked at this list, I thought it's obvious that what we saw that for some countries, the HLCA study has given a big motivation to start doing more things in the area of health literacy, but not for all, because when you, I hope I'm doing it right, Bulgaria, Greece, they were also part of the study, but Poland, but now there's nothing. Not much, let's say, not nothing, but not much. In Finland and Latvia, health literacy is unknown. This is a particularly difficult slide. It's not a difficult slide. It was difficult to make because we got a lot of information on one hand of the number of initiatives which were in a country, numbers of programs, numbers, and they are on the bottom. But on the other hand, we got more descriptive, qualitative information about what was happening in a country. And we have discussed this in length with the people from the European Commission, because when you only look at the number of initiatives, you get a strange picture. So we have also included the more descriptive data that we had, the qualitative data, and there we could come up with this overview of where all countries in Europe stand, with how far they are, which kind of activities they do in the area of health literacy. And then you can see again that only in the programs or policies in Austria and Germany and Ireland and Portugal and United Kingdom, evaluation is really already a part of some of the programs, not all, but some. So the conclusions of our study was that many activities are still in the beginning of the policy cycle. I'm now giving you a kind of overview over all countries, but many programs and many activities are in the earlier phases of agenda setting, problem definition, and there are very few who do the whole policy circle with evaluation, and then from there learning for new interventions. Evaluation is not an integral part, and when it is, most time the outcome measures and instruments are basic. So we are very hesitant in saying what is a good strategy for a country or what not. Even so, because countries differ very much. They differ in the way they are organized, how do you say that, administratively, but also their healthcare system is different. It's very, we don't want to set out good countries and bad countries or something like that. That is not the aim of this whole study. It's just a description of what is happening. Few countries have national policies or strategies, but that doesn't seem to hinder other countries to do a lot of activity. So that's we have the 6 with the national program and 10 others still having a lot of programs and activities. So what is a big conclusion of this part of the study is that initiatives in countries are often fragmented. So a more pragmatic and evidence-based policy in the member states might be beneficial with respect to the outcomes of the activities. Thank you very much.
Should I take it from here?
Sure.
Thank you. No, I have a one of these.
If it's in Portuguese,
Yeah. Well, thank you very much. We issues the subpopulation of the young and adolescents in terms of the mental health one, which is really a major problem, and they will be open to questions. Also, an overview of what is going on in Europe. I was very happy, very happy. So we have 15 minutes, 20 minutes before coffee break, and then come back at 6:00. So please, the floor is open for your questions. I would just then make the question as short as possible, please, so most people can ask things. Thank you very much. There are some microphones. Okay, good one.
Good afternoon. Thank you for your words. My question goes to Professor Paulo and to I'm Tania Morgado, and I am a PhD student, and I would like to to develop and test an intervention to promote mental health literacy of adolescents in school context. It's very difficult, like you said, because we don't have models, we don't have concepts, we don't have theories. And I'm very happy because you are working on that, but I need this for now. So I know Professor António Jorm because he was in Coimbra in the last year, and I know her concept and the components of the concept. Do you think it's possible to create an intervention using the components, because they have the first mental health first head program, but it's just a component of the concept of the author. So what do you think about it?
Okay. Thank you. This is at the end of the day useful approach. He has demonstrated, because he has also developed interventions. I think. What is your objective? Who is the target group? Are you targeting the adolescents, or do you? Yeah. Okay.
After that, maybe the adolescents on the 9, just reading and about the work of Professor Jorm. He developed the Beyond Blue in Australia,
yeah.
But I would like to work with anxiety, so I have some difficulties.
Yes, that's the difficulty we have in that field. Approaching or targeting the children and adolescents that we have, we have a lot of options, and we have some gaps that we have to fill in if we want to continue. I think one talk to the people, communicate with people who are working on that. The other point is that we critically reflect about our own work. So it would be nice if you could is a project that would help a lot in building up the understanding. If the intervention works, showed up here, working in cycle with your project, that could help a bit. We have made experience. We have developed a teacher training program on dealing with children of mentally ill parents. I know that here in Portugal there is another initiative led at the University of Aveiro. It's a colleague of ours, Aga Almeida. She is currently developing an online teachers, and she's focusing on suicide prevention. So this is the same framework, the same idea to improve the mental health literacy of those who are surrounding the children. In your project, it seems that you want to directly target the children, and so we have to approach them differently than we did it. And so this is what I can only recommend.
Sure. Okay, thank you, Paulo. You mentioned everything I could mention, but from that point on, we are partners. So we may stay in contact, but just one thing. We have to be very, very careful when we address the students, not to disclosure. Students at school, sounds so nice. But the problem is, we want to, because it may be very stressful for them to about my living conditions, my parents, a lot of diseases adolescents have, that this is really a problem for them to talk, to make them as strong as possible in public. And the same is with teachers, just to show them what they could do. Okay, just at the beginning of our cooperation. Huh?
Thank you. Professor Isabel, then you. Were you before? I'm sorry.
Saying how much I appreciated the presentation. Jany, thank you for the good news. Although we feel that the policies and programs is not so, also it should be improved. But anyway, it's good. And it was very follow the methodology that you presented. Concerning the presentation of Paulo and Ullrich, yes, I think it's not easy at all, especially if you are looking for health literacy. You have good references like Piaget, and as you know, require different approaches of the questions has to be targeted to Vygotsky and Paulo Freire. it was how you are going to proceed councils of health literacy, in which group exactly you were targeting, if you are targeting or children from 0 to 14. And about the determinants, also I'm looking for understanding how which methods will work better than others, and I didn't see there about critical. So I would like that health literacy, as it has been discussed today, is the outcome of health education as one of the determinants of health literacy. I propose to analyze the process of improving health literacy with children.
Because we don't have the answer. That we will be able to present some answers in the future. We have just started, and we're at the same point as you are, with all the uncertainties, with all the open questions. We made the diagnostics, so we can say, and this is what we depicted today for the future. And we are in the privileged situation that we can tackle this, and that we want to tackle it. And we have another privilege, is that we have the interdisciplinary work in our child health. What does it mean, child development? In the end, what does it mean, child health literacy in this context? It is not a strict strategy. It's like driving through the fog. You have some lights, you follow the lights, and you try to develop it, and then you try to present and to discuss it with you, to get new inputs, and to go also into what we find the body of literature. So it's a general answer that I can give right now. I'm sorry.
Yes, me too. Actually, maybe with the different age groups, something will happen similar to the different IQ levels or something. This is really a problem to ask children for their health literacy, and and therefore, Paulo mentioned the fog. Okay, yes, why not? But going with qualitative methods, we're starting with that and trying to make them more objective. And we are in the families. We try to be as close as possible. Same with the determinants of health literacy. That was our starting point again. We are talking about health literacy interventions. But we haven't got anything about the etiology of health literacy. Our focus that is called the explanandum focus. Which determinants of health literacy can we really focus on? Tell me. To say it's social gradient is not enough. What is it? So, as usual, it's multi-level what we are doing. Some are doing research on etiology. What a pity. For me, it would be much better to work closer together and to structure our work into intervention.
Just to follow up on Isabel's question, so you're working with kids 6 years old and up, and your adolescents are how old, or is it?
Okay, 6 years old and up in the children's position. No, it's a little bit earlier. It's
16, 15,
no, it's
16 on one slide you had 9 and 10-year-olds.
Yeah, yes. But we're starting at 10 of the children, but you're starting with 6 years. Main focus is 9 and 10. Okay. At the end, our results are 9 and 10, but we are starting to make short surveys with 6 years old children.
That differs from project to project.
Okay.
It was for us important that the age groups are not, or that we do not include too many age groups in one project, that we focus rather on either children or either adolescents to have a higher degree of validity in the data that we will produce. We have the smallest, the youngest age group is the Media Protect group. There they will have a look, develop a measurement tool for children 9 to 10 years. Our National Institute of Health, the Robert Koch Institute, is focusing on the adolescents. I think it's by project. And at the end, we have, well, it's not representative, but we have at least once each age group.
We have time for one final question, please.
Sheko, I work as a public health physician here in the greater area of Lisbon. And I'd like to obviously thank all the speakers for their presentations, and I have a question for Dr. Jany Rademakers. Like the way you chose to collect your data, what type of influence do you think that the fact that you chose just to go with health literacy as a selection criteria had on your data? Because obviously it's the way our contemporary experts choose to name that nowadays, but it was preceded by health education, information, knowledge, all sorts of other, well, possible results. That because looking at your rather difficult to build chart that you presented by the end, I mean, it seems rather odd that France or Finland scored 0, if that has worked as a selection bias or any other views you may have regarding that.
Thank you for your question. It definitely. And to my defense, I can say it was not our choice because it was our but we have had long discussions about what to include and what not to include, and it was relatively easy for ourselves to look from countries of which we could understand the language, but there were let's say in the core research team, we couldn't handle all languages from the European Union. So when we got 26 interventions from Hungary, we had a problem, and we asked the country coordinator, is this really health literacy? And then he said, yes, it all contributes to health literacy. And then we think that it's definitely a selection bias. We have included some programs from France which were on the edge because we really thought they should be included, but that's why I say it was not rocket hard science. It was more deliberations between the research team with the country coordinators going back and forth, having currently, as we speak, 5 peer reviewers are reviewing the whole report again. So it's more, I wouldn't call it a consensus report, but there is a lot of consensus. There was one really important question. Is it important that people call it health literacy, or is it not important at all? And there we were very clear that of different, because we know already that health education, when you target it on a people that cannot understand your written material or who are not able to communicate with their healthcare, health literacy comes into place. So we think it has an added value to use the concept because it focuses on the differences in the knowledge, the motivation, the skills of people, and that therefore we thought it was legitimate to do it this way.
All right, thank you very much. With this, we have to close this session because you have to be back here at 4, and you'll be back in about 15 minutes. Thank you very much.